Thank you for that far too kind introduction. It is truly a pleasure and an honor to be here at 840 Walnut. These are my disclosures, financial disclosures, and the only one that's germane relates to Focus ROP. It's a ROP screening software, which I'll be using as an example later on in the talk. My picture isn't as quite as crisp focus as Arunan's, but obviously I Googled Arch to find some photos, and I like this one because it just reminded me of what it was like to be around Arch. Many of you know him so much better, and I look forward to having an opportunity to meet Julie later. But I think a succinct way to describe how it felt to me to interact with Arch is whenever I walked into a room and Arch was there, the room was always a little brighter. And I think that perhaps says it not very eloquently, but perhaps succinctly. You, I think, also far more familiar with his pedigree than I, having grown up in Newfoundland, Memorial University, undergrad in Med, University of Ottawa Hospital's residency, a fellow here, finishing in 1985, whereupon he joined what was then Retinal-Vitreous Associates, and of course a member of the Wills Retina Service for many, many years thereafter. Arch had a fairly wide-ranging intellectual appetite when it came to vitreoretinal disease and published in a variety of areas. In particular, as Arunan mentioned, the Venn diagram of our interests overlaps in pediatric retina. In particular, there are two things that we worked on that I think were particularly important to both of us. First of all, the group here in Philadelphia were at the fore of the battle back 15, 20 years ago over whether laser photocoagulation could meet or beat, if you would, cryopexy as a method of retinal ablation in retinopathy of prematurity. And as you can see, may I borrow back that pointer? The Philadelphia group is very well represented and, in fact, anchored much of this work back at that time here. Then we also had an opportunity to work together on what was called the ICROP-2, the revision of the International Classification of ROP, where there was further elaboration on the clinical features and importance of pre-plus disease and aggressive posterior retinopathy of prematurity. And Arch and I were together here as well. This is a meeting that for this project that Anna Els, seen here, hosted for us in Calgary. As you can see, the beautiful background, and there, of course, is Arch, and there are a variety of KOLs, as they're known in the industry, key opinion leaders. Here's Dr. Flynn, Dr. Tracy, David Wallace, Alistair, Earl Palmer, your very own, Philadelphia's own Graham Quinn. There's Bill Good back there, and others. So I've had an opportunity, as I was sharing with Arunan earlier, to give a couple of memorial lectures. Fortunate enough to be invited to do so. This is the first time for me, though, doing it for someone who was who I considered a personal friend as a contemporary. I think, again, speaking to you who knew him better, Arch, you're well aware, Arch had a number of passions. First and foremost, family and friends. Residency and fellow education were important to him and dear to his heart, and that's another shared interest, performing arts, and also underwater photography. And I'm not sure if you're familiar with Arch's work in this area. This is just one of his images, which is particularly striking. I think it's called a nudie branch or something of that nature. It's an image that he submitted in competition in 2004 successfully. So here I am with my bag of coals that I'm bringing to Newcastle. Giants of ROP still stride these halls. Aaron asked me to speak about some issues that are of interest. My only regret in this regard is that I don't have more time with you, because I have so many things that I want to share with you. What I thought I would do is to hit on a couple of things that are fairly topical and of interest, and away we go. First, obviously, by way of background, ROP remains relevant. It's still a problem in developed parts of the world, such as ours. The incidence has not declined in spite of our advances in technology, and in fact, since our neonatology colleagues are increasingly successful at keeping smaller and smaller infants alive, severe ROP is indeed more common, as we see in either 23, 24-weekers or 22, 23-weekers who are multiple gestations. Thus, the younger infants angle. And of course, in other parts of the world, infants suffer more from infectious etiologies and nutritional etiologies, but in transitional areas, from an economic perspective, increasing NICU availability leads to a little boomlet, if you will, of ROP. The risk and severity determinants remain the same. The smallest and the sickest babies get ROP. This is a statement that usually engenders a modest amount of controversy, but it is the case that with current care technologies, theoretically, the failure rate for ROP should be exceptionally low. And that statement is based on the fact that prompt diagnosis and treatment with an ETROP style and timed laser yields a success rate on the order of 90%. And in kind, that 10% of children who develop some measure of retinal detachment, if diagnosed early and managed effectively, again, meet with anatomic success and significantly positive visual outcome 90% of the time. In reality, however, the actual success rate worldwide is much lower. And so we decided to kind of eat our own cooking, take a look at how we did in our own center, looking at ROP outcomes for a 10-year period of about 1,500 children surviving to discharge. The numbers you see here are going to be pretty close to industry average, on the order of 5 to 6% of children progress to requiring laser. The laser was successful on the order of 90% of the time. There's about 10% required surgery. And overall, unfavorable outcome was relatively uncommon, and NLP blindness was exceptionally rare. So this all sounds very good, and usually it's at this point of the conversation that it sounds like we're sort of touting our own horns when we present these data. But these results are not unique to us. In fact, there are similar outcomes at many other centers, and what these centers share in common is that they are dedicated centers of excellence interested in ROP, essentially from screening through surgery. And of course, Children's Hospital here in Philadelphia is on that list. So the importance of that point, though, is that I think many times when a child does poorly with ROP, the refrain is, well, this child was born at 23 weeks or 24 weeks or 22 weeks, as if it is a foregone conclusion that they will do poorly. And I call this the myth of biologic inevitability. Now, that's not to say that some children don't do well. There will always be some children who don't do well. But these children are not invariably doomed to doing poorly. And I think that the key to optimizing outcome in ROP is to have as effective a safety net as possible. And the core elements of that, and you can't necessarily choose only inborn infants, depending on where you work, but inborn infants seem to fare well or better, likely because of monitoring and more timely intervention. Experience is something that matters, and I'm going to chat briefly about that. But ROP is a very diverse disease, as many of the diseases we tend to. And there are the core classification schemata that we all see. But in many ways, developing a vocabulary, both verbal and visual, to tend to children with ROP is like learning a language. And the more fluent you are, the better you will be. And the less fluent you are, the more likely you are to stumble. Diligent screening, and we'll talk a little bit about a paradigm shift that I think is a positive change in that regard. Timely treatment and, of course, effective therapies. But as I mentioned earlier, we have some fairly effective therapies. So I like to look at our ROP as sort of the management cycle, or you could change the word management to risk cycle. Prematurity, of course, is the sine qua non predisposing factor, and then pre-threshold disease, stage 4 disease, and more advanced stages of disease are all outcome inflection points. And we have ways to interact with the disease and mitigate its course meaningfully, even if not in absolute sense, in a generally positive way. So I mentioned our descriptive vocabulary, and I know we have a range of levels of training in the room, so forgive me as I go through very briefly the fact that we have an established nomenclature. It allows us to talk to each other about the same thing most of the time. The issues having to do with staging and zoning from immature retina, which isn't a formal part of the staging category, the staging classification, all the way through to a very complex disease. I think the former is relatively easy to learn. The challenge is in learning the latter. And just like speaking a language, you can learn it in a book, but until you actually force yourself to speak, you really don't become fluent, because the essence of language is idiom. And the same thing is really true for developing a visual vocabulary. You need to be familiar, one needs to be familiar if they're interested in this disease, not only in the classic stages that they find in the book, but in all the nuances, the idiom, if you will, to help us describe and understand how an eye goes from this, and perhaps difficult to see in the image here is the fact that the vascularization terminates here in this premature infant, to this, which is the same eye of the same child who then develops ROP. So we all know how we talk about that with words, but we don't necessarily all have the same vocabulary when it comes to our visual understanding of the disease. So the earliest findings in a premature infant really don't relate so much to ROP. They relate to things like diffuse vascular attenuation, diffuse vitreous haze, relative pallor of the pigment epithelium. These are all the characteristics of the profoundly premature fundus. And these factors are important in the early determination of abnormal retinal vascular development. Again, difficult to see here, but difficult to see in real life. And this is a figure out of the ICROP2 study. This is simply a point of immature retinal vascularization, a vascular junction without yet having a demarcation line. So this is pre-stage 1 disease. Here, again, a subtle demarcation line with the pallor of the fundus and the prominence of the choroidal vessels as a consequence thereof. It's easy to imagine when you're examining a child who's difficult to examine, the vascularization proceeds more peripherally. And then the more classic images, stage 2. Here's stage 2 with sinusoids and popcorn. This is neovascularization. That's not stage 3 until it touches the ridge. Down here, again, fairly simple when we see it schematically, perhaps less so in real life. This is also stage 3 disease. And then on to stage 4, schematic, low-lying stage 4 detachment, not very much elevation, but very close to the money. And here is a stage 4 BI, where here is the disc, and this is a stalk, residual stalk tissue that comes to a drum head of proliferation in this stage 4 funnel detachment, where they establish a proliferative sheet from one end of the drum head to the other. Here is an eye that is a clinical stage 5 with an open anterior funnel and a closed anterior funnel. So we have a visual vocabulary. That vocabulary was expanded upon by the ICROP2, where not only pre-plus disease was mentioned. This is plus, of course, a marker of aggressive disease, but the entity known as aggressive posterior ROP, important for 2 reasons. Number 1, because of the relative subtlety with regard to clinical findings. One will look in the eye and see that something isn't quite right, noting all the dilation and tortuosity, but not perhaps quite as apparent will be what the flat stage 3 neovascularization that is typical of posterior disease. So an example of subtleties in clinical findings. This is a child who had aggressive posterior ROP. Here's that caput medusa appearance of the florid plus disease in the posterior pole. You notice that out here things are avascular, and there's this intervening zone from the termination of these retinal vessels, abnormal though they are, to the avascular retina. This child was correctly determined to be in need of laser, and laser was performed, and things are looking well. And then 2 weeks later, there's just a little bit of condensation here, which then progresses and contracts further flatly, as is typical of these eyes, flat posterior contraction, and leads to that. So we have an eye that was diagnosed appropriately, looks like they were treated in a fashion that seems like it was appropriate from the images that I showed you, and yet who still fared poorly. And so as we look back at this and do the instant replay, same eye beforehand, AP-ROP is recognized and lasered, but I'm going to draw your attention to a feature here. The laser was brought to here. The vessels terminate here. The retina beneath this flat stage 3 ROP is avascular and also in need of ablation. And so that was what at that time was not recognized. So here's where the vessels first came out. Note also that the plus disease considerably regresses. But then this area needs to be filled in. Because if it isn't, you'll see not just a early vitreous condensation, but you will then see a little bit of recrudescence of plus disease. There's more tortuosity starting to happen here. You have a localized flat detachment there. And then, of course, the conclusion that I alluded to earlier. So it's hard for everyone to speak this language, if you will, equally well. Because of differences in experience. Not everybody can see 100 children with ROP in a year. So how then do we bring as many children as possible into that 99% pathway where they're likely to have a good result? So effective screening is arguably the most important aspect of ROP care. I spend most of my time talking about surgery, but surgery really isn't as important as this, because without entering the pathway, they don't get access to care. Surgery is rescue work, and the idea is to tend to things before it all breaks down. So the availability of effective screening underscores the importance thereof and identifies it as the critical component of an ROP safety net, because, as I mentioned, it's your access to care. So how then to think a little bit differently about screening? One is the advent of genetic screening, and this is, no pun intended, an area that is very much in its infancy. We aren't the only ones who are doing work in this area, but we've taken a look at children with what we feel is atypical ROP, either children with particularly aggressive AP-ROP who fare poorly in spite of timely and appropriate therapy with, yes, a second laser session to get that flat, that area of retina under flat NV, or babies who are unusual in other regards, the big baby ROP problem. Not as much of an issue here in the United States, but elsewhere in the world, in India, for example, the phenomenon of larger babies getting ROP is well recognized. We have identified a double mutation in the Frizzled-4 receptor, which is a critical receptor in the Wnt pathway, likely to play a role in vascular development, but certainly not a definitive enough finding yet to hang our hats on and start widespread genetic screening. The other approach is to revisit how we are screening children conventionally, clinically. And binocular indirect ophthalmoscopy remains the so-called gold standard, the same thing we've been doing for 20 years, not truly compatible with EHRs in that the data are then interpreted by the examiner, and that interpretation is transcribed. So the raw data themselves, like your potassium level, et cetera, do not make it into the electronic medical record. The fundus details are generally poorly documented, and treatment adequacy is also not effectively documented. This is a drawing by my senior partner who has a fair amount of experience in ROP, and that's his rendition to your left, and that is the image to your right. And I think the question as to which image is better is obviously rhetorical. So the weaknesses of the current approach are that resource application, first of all, is conditional. How often you see that child is based on how severe you think the disease is. So a child with no plus disease is not as commonly seen at 2 weeks, a child with some measure of plus disease more often. And the problem with that is it presumes that the examiner is always right. It also does not protect the child who has a variable course. For example, in that intervening 2 weeks, has some measure of sepsis or pulmonary failure, et cetera, who may exacerbate in a time frame that is atypical. Also, these children fall between the cracks on transfer from facility to facility. So we've all, I think, seen the scenario, those of us who care for these sorts of children, who will leave to go to another facility for repair of the tetralogy Fallot and then come back alive, but with advanced ROP. Also, as I mentioned, experience is variable, and bedside ophthalmoscopy limits our ability to get second opinions. The ideal, of course, is an expert at every child's bedside every time. Not attainable without a dispersive technology, if you will. And then the full care team is not engaged. And once the child leaves the hospital, the last member of the team is the most important member of the team. And part of the reasons that the parents aren't engaged is because the eye is a black box, not just for them. Again, we had the experience of walking onto the NICU. The child is just about ready for discharge, 36, 37, 38 weeks. We examine the eyes and we proclaim that the child has a blinding disease, can't leave, has to have general anesthesia, and so forth. So having a way to render the information accessible to all of the team, I think, fortifies the safety net lying beneath the child. So apart from shifting from binocular indirect ophthalmoscopy, we've assumed a systematic schedule for exams. Every child is examined on a weekly basis using a digital imaging construct, and then those images are put into a software program and the doctor who is responsible for screening is notified, and the screenings are done in that fashion. Every child gets a live bedside exam prior to heading home, but every child gets most of their, on average, 5 exams when they're in the hospital in this fashion. And so the advantage of this approach is it addresses many of the risk vulnerabilities. Consistency in examination. It allows you to leverage experience because images can be sent anywhere you wish across the globe for an expert opinion, and it also tends to consolidate the infant's team. The nurses who take the pictures become fairly facile at identifying plus disease. The neonatologists also obviously have a preference for being able to understand why it is that the child is staying other than the words that we give them, and also the parents can get an idea of what the nature of the problem is. So the primary drivers of the decision to treat are plus disease and posterior ROP. And I mentioned that as a common criticism of digital imaging systems, or the digital imaging approach, is that you don't get adequate resolution in the far periphery. While that is true, that's not where most of the information that assists you in determining the need for treatment sits. It's important for clinical trials, but not necessarily for assessing if a child is in trouble or not and needs a bedside exam and a possible treatment. And in fact, the posterior pole is the strength of digital fundus imaging technologies. So we have assumed a system that we incorporate into the infant EHR and standard delivery of ROP screening services in this way. The physician stays involved. The common concern that's often articulated, particularly when I start talking about the NICU nurses being able to discern plus disease, is the doctor woven out of this, A, and B, is that smart? And the doctor is integral to this construct, both for image interpretation and for the bedside exam prior to discharge. But in response to the question of will automated disease detection replace physician diagnosis, I would submit that everyone wants a plane to have an autopilot, but nobody wants a plane without a pilot at all. The other advantage of inpatient exams weekly is this really corresponds to our construct for examining patients with glaucoma, for example. We don't often place much credence in a single field, particularly if the abnormalities are subtle. However, that field, seen against the backdrop of all the other fields, allows us a much more natural way to view the disease not as a snapshot, but as a film over time. So we do standard photos. This is a photo set from the ROP study, which we did about a decade ago, demonstrating the utility of digital fundus imaging in screening. 12 images are generated. They're uploaded into a management software. This is the software that we happen to use. This is the FocusROP product. There are other products available. So I use this by way of, or I mentioned FocusROP as by way of an example of something that can be used. It is what we happen to use. The images are uploaded. The physician interpreter is notified with feedback loops built in. If the doctor doesn't communicate back, then additional notices are sent. If that doctor doesn't communicate back, the second on the call string is notified, et cetera, as they would if you had an open globe that came into the emergency room and you didn't get a response. Images are then interpreted, and those data are placed into a web-based ROP surveillance solution, fed into an algorithm, customized for ROP. An answer is generated real time. It runs in the background, and recommendations are shared then with a hospital-based care team with a very short feedback loop. So again, an advantage of this, apart from all the record-keeping components and the ability to leverage expertise, because now these images can be sent out. To my mind, these are images that provide courtesy of Darius Mashfeghi, my colleague at Stanford, who is also very interested in telemedicine. And you get to evaluate ROP more like this, which I think is a more meaningful way to have a nuanced sense of the rhythm and cadence of the disease as it progresses. So we're not the only ones to do this. As I mentioned, Dr. Mashfeghi does it. He has a system of all of his own. There are analogous systems in Germany. Bridget Lorenz has also written on this topic, and there are probably every 3 or 4 months I'll get an email with another software product that has been designed to address this need. So I think there are going to be a lot of players in this space. I think the more important thing is this kind of a care shift is more likely to get the children at risk into the care pathway, and I think the children will fare better as we shore up our screening construct. So when I used to give this talk about 5 or 6 years ago, I concluded with this slide. In the future, we will employ remote digital fundus imaging to ensure a proper level of care, and I think that the time is coming that the future is now. This topic is also under investigation, as I'm sure everybody here is aware, because the study center is based here in Philadelphia. Graham Quinn is chairing a study on telemedicine for ROP, looking also at some of the important systems issues, such as systems efficiencies, cost containment, infrastructure issues that will really render this body of literature much more three-dimensional and I think prove useful as it is implemented more broadly. I thought another area that is topical and controversial is the issue of anti-VEGF therapy in pediatric retinal diseases. The publication of the BEAT ROP data notwithstanding, this is from the New England Journal in February, almost 2 years ago now, by Mintz Hintner and colleagues, speaking to the use of anti-VEGF agents as compared to peripheral scatter laser photoablation in a prospective randomized clinical trial. One would expect after an RCT that demonstrated statistical significance that this would be a widespread, that there would be widespread adoption of this therapeutic approach. And in fact, while it is still used by some in exceptional cases, it is not a therapy that has been universally adopted as standard of care by most ROP thought leaders. Again, many use it for occasional cases. I know of very few who use it universally for the management of any phase of ROP. And in fact, I will remind you of the flurry of editorials that came out articulating the concern regarding an anti-VEGF approach for ROP, quick on the heels of the publication of the Beat ROP data, all of them expressing in some way, shape, or form caution, a call for a more considered pace, and so on and so forth. And the common denominator to those editorials had to do with these issues relating to the Beat ROP. Questions regarding efficacy, safety, follow-up, choice of drug, and drug dosage. Speak briefly first about efficacy. For Zone 2 ROP, there was no statistically demonstrated benefit to pharmacologic versus ablative therapy. The laser failure rate was only 12% also in that cohort, and that number resonates with the industry standard. Those are the ETROP numbers, roughly. The statistical significance was only seen in Zone 1 disease, and it was highly significant. However, note the laser failure rate, 42%. Now, there are other studies in the literature speaking to treatment of patients with this zone and stage of disease. Note, first of all, that the Beat ROP study had 34 eyes, and the other studies that I've listed here all have eyes of a study population that has a similar order of magnitude. Treatment failure here is somewhat variously defined. Recurrence of neovascularization by 54 weeks, and these are treatment failure defined as progression to RD, but this is usually a precedent almost invariably for Zone 1 eyes to that. So they're reasonable surrogates for each other in terms of success rate. If you graph these other studies against the p-value with these data used as the laser data as opposed to the Beat ROP data, I think you can see several things. First of all, these data do cluster together. They are of a similar order of magnitude and would not have been statistically significant as compared to bevacizumab if the laser success rate had been in this range. And further, that Beat ROP in this regard is an outlier, even though attaining high statistical significance. So it does raise the question that, or make the point that had outcomes in the laser cohort been in line with published series, probably bevacizumab would not have shown to have been statistically significant in the treatment of Zone 1 disease as compared to laser. Well, then what are the safety issues? One of the first things that the authors concede in the article is the Beat ROP was not adequately powered to evaluate safety. Nonetheless, of the 7 deaths, the majority occurred in the drug treatment group, and the preponderance of those were for pulmonary reasons. So understood and yet difficult to ignore. So how do those data resonate with other information that we have about the use of anti-VEGFs in infants? Well, first, bevacizumab has been measured in both contralateral eyes and the serum in animal models after intraocular administration. Furthermore, bevacizumab and ranibizumab have been shown to decrease serum VEGF concentrations in infants after intravitreal administration. This is a graphic from Herster et al.'s presentation this year at Euretina, published in Acta Ophthalmologica. A child received bilateral 0.2 milligram ranibizumab injections. Serial VEGF concentrations were followed and dropped to undetectable at 3 weeks. Now, when you look at this graph, you see that it bounces back up to 4 weeks post-injection, and I think it's hard sometimes to stifle out, well, okay, so what? Well, no one knows for sure the so what. There are animal data that suggest there are reasons for concern. Lacrosse et al. Back in 2002 treated newborn rats with a single dose of a systemic VEGF receptor inhibitor, and they noted, as compared to controls here, audience left, reduced septation, large air spaces, and changes that persisted into adulthood in the treated animals, here in infancy and here in adulthood. Well, moving on to follow-up issues. The timing of recurrence for the Zone 1 eyes in the Beat ROP study was on the order of 20 weeks after treatment at 34.5 weeks on average. Well, the primary endpoint was 54 weeks, which was the mean age of recurrence. But note the range of recurrence. In fact, eyes with zone 1 stage 3 ROP recurred up to 7 months after administration of bevacizumab, and it is therefore likely that all recurrences were not captured in the course of the study. So the true frequency of recurrence is not known, and the true endpoint of treatment remains an unsettled issue. And that will segue to the appearance of ROP following pharmacologic treatment. And this is the part where even if you speak the language of ROP with regard to visual fluency, if you will, now there's a new dialect. And I'll demonstrate that to you here. This is a child that was treated by my colleagues Paula Dorta and Andres Kitchenthal in Chile. This is a child with very, very posterior disease, not really much vascularized past the umbo. This child was treated with anti-VEGF agent, and at 40, almost 47 weeks here, you'll see that on the one hand there's no ROP, but note also that these vessels are not normal with regard to course, nor are they normal with regard to caliber. Now, regressing ROP also results in vascular abnormalities, but this sort of thing is not something that we are used to seeing with vessels doubling back and the like. Furthermore, when ROP reactivates after pharmacologic treatment, it reactivates in a different way, not only at the vascular-avascular, leading vascular-avascular juncture, but also back at the original vascular-avascular juncture. And this is an article by Hu and Shapiro and Blair et al. In a relatively recent Archives of Ophthalmology publication. The issue of persistent avascular retina, I think, has gotten a fair amount of press. This is a child who was sent to me for vitreous hemorrhage, non-clearing vitreous hemorrhage in the companion eye. Both eyes have been treated with Avastin. I was able to do an angiogram on this eye, and you'll note several things. The obvious one is the persistent peripheral vascular non-perfusion or non-vascularization. You can see at this fairly late recirculation phase that there's some smoldering hyperfluorescence here, suggestive of blood-ocular barrier compromise and perhaps reactivation. But also note the fovea. This fovea looked clinically normal, but it's clearly not normal from a vascular architecture perspective. We have no idea what the impact of vision is of this sort of maldevelopment, if you will. Here's a child with a symmetrical posterior ROP of a similar sort that I showed earlier. Disc, hazy vitreous, barely vascularized, really not all the way around what would be the FAZ. This child was treated with anti-VEGFs, and even retinal detachment looks different after anti-VEGF therapy. Instead of the typical postero-anterior tractional vectors that one sees in zone 2 ROP, where the retina is drawn the ridge is drawn anteriorly, these children detach flatly. This is a hyaloidal contraction type of detachment, which should resonate with you in your visual vocabulary to the case that I did the instant replay on earlier. Flat hyaloidal detachment. And these eyes can be addressed surgically. Both these eyes were treated with plasmin, and we get retinal reattachment, but notice the marked retinal attenuation. It's difficult to discern the retinal vessels except for at the disc. Clearly there's a fold in the horizontal raphe or close there too, and this child sees, but the vision is limited by all of the anatomic factors that I just mentioned. So again, even detachment looks different after pharmacologic therapy. So why does that matter? If we don't yet have enough of a visual vocabulary in terms of how these eyes behave after treatment, it's difficult to follow them, because then you learn anew with every child you follow. As to drug and dosing, bevacizumab has largely been used by virtue of its cost convenience. And even the dosing is generally done by some, a simple fraction, if you will, of an adult dose, essentially chosen empirically, and the only exception to that was the estimation, the stoichiometric estimation John Sears published in the BJO in 2008. But these are the range of doses: half, a third, two-thirds of an adult dose. The goal, in fact, though, as we treat children with anti-VEGF therapy, and it's obvious when you say it out loud, is not simply to encourage regression of the aberrant vascularization or the neovascularization, if you will, but also to allow normal retinal vascularization to proceed uninterrupted. And when we have eyes like the one that I showed you with peripheral vascular non-perfusion, you can see that clearly both can be impacted. So the challenge is really, pharmacologically, how can you split the hair? Publication by Luddy et al., as it happens, back in 2010 on VEGF evaluating VEGF trap in the oxygen-induced retinopathy model in the Beagle, which is the model that is said to most closely approximate human retinopathy of prematurity. They tested 3 doses, 5, 25, and 250 microns. All 3 doses inhibited neovascularization, but the 5 microgram dose, the lowest, blocked pathologic neovascularization without interfering with retinal neovascularization. This resonates with those of you who are familiar with it, with Bob Avery's discussion regarding very small doses of anti-VEGF agents in adults having a similar impact on disc neovascularization in diabetes on the order of a 6 microgram dose. So these findings beg the question, A, are we using the right drug? And B, are we using the drug at the right dose? And again, both those questions asked by Dr. Avery in his editorial. Well, how about the issue of protecting children? Neonatology has had many examples of therapies adopted because of short-term benefit ahead of proper studies. This is the one, of course, with which we are all most familiar, interferon for capillary hemangioma and ensuing spastic diplegia, postnatal steroids to more easily wean children off a ventilator, and late CP are but 3 examples. This is a heading from a recent editorial in JAMA speaking to the issue that many drugs used on infants in neonatal intensive care are used based on extrapolated experience from adults and have not been formally tested in the children, such that we often have insufficient efficacy and safety information with a resultant knowledge gap. When that is the case, as I would submit it is in the use of anti-VEGF therapy for ROP, every preterm newborn is enrolled in their own uncontrolled and unapproved trial that will not yield data of substantial value, except for beyond making that particular physician more fluent as his personal or her personal experience grows. So the question is not whether BEAT-ROP provided new information. Clearly it did. The question is, however, did BEAT-ROP provide enough information to support the routine use of bevacizumab as a new standard of care for ROP? I.e., did it bridge the gap that we typically look to such a trial to bridge between the case literature and randomized clinical trials? Because it looks like a top-shelf clinical trial, prospective, randomized, controlled, multi-center New England Journal publication. But in many ways, it wasn't, with regard to not providing the population of physicians caring for these children with enough information about efficacy, safety, dosage, and follow-up to really know which way to go. So there is an informational void with regard to intravitreal anti-VEGF use. It's difficult to, spell check, difficult to recommend routine use, particularly in the setting of an available standard of care, alternative, proven effective treatment in randomized clinical trials. So this begs the obvious question. A randomized clinical trial is in order, and the cost of such a trial renders it impractical without industry support. I was pleased to hear when I've been at meetings in Europe over the last 2 weeks that the word on the street is that Novartis is planning just such a randomized clinical trial employing Lucentis in Europe, possibly extending to the United States, to address this issue regarding drug dosage. But until then, if you use an anti-VEGF, and I do as well, beware the unexpected pattern and potential for unfavorable outcomes associated with reactivation of ROP after anti-VEGF monotherapy. And I'll just end with another one of Arch's images. When you look at his images over the passage of time, it's clear that he got better and better with regard to both framing and illumination. And this picture has an almost textural quality that I think makes it beautiful. So I thank you again for the honor of inviting me. It's a true privilege. I'd be glad to take any questions.
Those attenuated vessels that you showed, are they, I'll have the microphone.
Which ones?
Typical for all cases treated with the Avastin? Or
No.
Okay.
There are many eyes, and this has not been my experience, and I have clear ascertainment bias because I see the ones that don't go well. And I also don't use it routinely. But of my friends who use it routinely, the usual rebuttal to this is most children do well. So, good question. Gives me a chance to appropriately disclaim. Yes?
Tony, great talk, great overview, and got a question and a comment. So it sounds like you don't, correct me if I'm wrong, you don't use Avastin as a primary therapy for ROP.
Correct.
And I think we can say the same thing here. We use it very selectively for refractory or unresponsive like cases. And have had very good success with it. Fortunately, we haven't need to use it much. But your points earlier, I'd like to underscore the notion of the team and the vigilance with regards to ROP management from the very beginning to the very end. We have a great team in place here. I don't think we've actually gone to the OR and had to go to the OR for a detachment in years for a homegrown case, a case that we've managed from the very beginning. Caught early, great screening, treatment promptly, and the trend for used to be scatter laser or near confluent laser, and a trend for more confluent laser. So heavier ablation in the non-perfused area with laser. And as you pointed out, that's a great case where there was relative undertreatment in areas, and with complete treatment, we almost never see a problem. And knock on wood. And again, the occasional rescue with Avastin has worked very nicely.
Alex?
That was really a wonderful talk. Thank you very much. One of the issues that's come up in the world that's really a challenge for organizations like Orbis and World Eye Mission is in the other, is that in the developing world where laser is not readily available, or someone to do the laser, obviously VEGF is much easier, much more available. Anybody can put a needle in the eye is kind of the thought. So, with all due respect to my retina colleagues, of course, but in the third world,
offense taken.
Does the landscape change in a way in terms of your interpretation and your recommendations? Especially, I mean, I understand it's in a quote-unquote experimental therapy. How would you advise those organizations?
No, I think that's a great question. For the price of one laser, you can treat an awful lot of babies in a rural Mexican town. Laser for ROP is not easy. It's the hardest laser that I do. Obviously, if the view is clear and everything is perfect, it's not so bad. But it's we call it Dr. Killen laser, DKL, in our facility. Laser through the tunica vasculosa lentis. When it's posterior, it's hard to get burns to take up, so on and so forth. So certainly it is easier, and resource utilization is a lot less for doing injections. So I get it. There are a lot of compelling reasons to do it, and many babies do well. And I think the answer is I think it's incumbent on industry to answer this question because of the issues that you raise. These are treatments that are going to be applied across the world, and this is my sense of, again, this, I don't know this is a fact. This is clearly hearsay, but that essentially that the European Union posed to Novartis that this was really sort of their moral obligation to speak to this issue with regard to dosage. So I think that there will be a place for anti-VEGF therapy. I, in the early days, was a proponent of studying anti-VEGF therapy. The problem I've had is, as I mentioned here, I don't think there's enough information for widespread adoption of the therapy. So I agree with everything you're saying, and I think the answer is going to be the clinical trial.
Of course, although you have a flat line for ROP incidence here, in the third world, Vietnam and elsewhere, the incidence is skyrocketing.
Absolutely.
Technology in the neonates is better.
So the catch-22, if I may, and I'll let you ask the next question in a minute. So the rationale is many times, well, we're going to use it in kids who are at particular risk of going blind. We only use it in the smallest and the sickest infants. Well, I could make the case that those are precisely the children who are at greatest risk of systemic morbidity. And so the questions need to be answered. I see it is a complex problem, and I acknowledge it in all of its complexity. I think we tend to think of it in simple terms. We won't know, but in hindsight, if this dose was fine, in which case, because of the kinds of things that I'm saying, kids went blind that could have been treated.
Phil Tasman and then
Tony, that was fantastic. I think it was a really balanced view of what's going on and what needs to be done. And you mentioned a few things that used to be thought to be important in ROP and modifying it, and they turn out not to be so. I'd just like to point out that one of the biggest proponents of Aston once was a big proponent of vitamin E, and that didn't work out. So I agree with you that it would be great to have a randomized study wherever it comes from. And the other thing is that these eyes are about, the volume in the vitreous cavity is about a third that of an adult eye. So I don't know whether you're using smaller dosages or not, but occasionally we are here. And then I have a question. In your comments about the big babies and the Frizzled-4 gene, do you test just the babies or do you test the parents too?
We draw blood from the parents as well.
Good.
Superb lecture. I really enjoyed it. And I agree with Carl about the dearth of really poor outcomes in the Philadelphia area. My partner and I screen between 12 and 20 babies a week. And one of the things that is confusing, and I do a lot of forensic work, and I get a lot of cases from all over the country, not in this area, where defining the exact time to treat with laser is not really well understood by a lot of our colleagues. And one of the things that we've been doing is, in the literature, there's a distinction between pre-plus and plus. And I think we treat stage 2 pre-plus, because to me, if you have dilated tortuous vessels, in the literature, the subjective interpretation of what is plus disease and what is pre-plus disease will drive any normal ophthalmologist crazy. So what we do is, and all of the people in Carl's group are the people that treat our ROP babies with laser. I think that should be really more defined, because a little bit of dilated and tortuous vessels and the speed with which it occurs are really indications for treatment. Am I sort of on the right track?
No, I think I understand exactly what you're saying. If I was going to be critical, I'd say you do the right thing for the wrong reasons. But I would be throwing a stone from my glass house if I said that and meant it. Interestingly, the data that I presented, that 10-year data, in the beginning of that 10 years, we were treating with strict cryo-ROP, criteria, 5 contiguous or more, 8, et cetera, et cetera, et cetera. What had happened in that 10 years, to be honest, is we had little by little drifted to what were very, very close to ETROP criteria, i.e. not requiring 4 quadrants of plus. Right? If you had 5 clock hours of neovascularization, 2 quadrants of plus, that wasn't cryo-ROP threshold, but it was, ETROP threshold. And so we had done much the same thing based on judgment. Clinical trials provide guidance. They're not Bibles.
Okay, for a limitation of time, let's take a quick 10 minutes, and then Mitch Feynman is going to run the case series for the next session. Thank you.